Good afternoon, everyone. My name is Meng-Shin, and I'm the Assistant Dean for International Relations and Research Collaborations, Faculty of Medicine Ramathibodi Hospital, Mahidol University. It's my pleasure to be the moderator of the online seminar, Prenatal and Preimplantation Genetic Diagnosis today, hosted by Changhua Christian Hospital in Taiwan. And it's our great honor to invite all the experts in prenatal and preimplantation genetic test and diagnosis from both Thailand and Taiwan. There will be two sessions of this seminar. One is today, and then the other one is May 30th. So please don't forget to join again on May 30th. And I would also like to take the chance to thank the advisors, Ministry of Health and Welfare, and Ministry of Foreign Affairs of Taiwan. Without further ado, I would like to invite Acting Representative of Taipei Economic and Cultural Office in Thailand, Mr. Wei-Ming to deliver the opening remarks for us. Please, Mr. Wei-Ming.
Dr. Nina Gao, CEO of Overseas Medical Mission Center of Changhua Christian Hospital. Dr. Duangrurdee from Ramathibodi Hospital. All distinguished speakers and participants, ladies and gentlemen, good day. My name is Herbert Shi, Acting Representative of Taipei Economic and Cultural Office in Thailand. Firstly, on behalf of the Taipei Economic and Cultural Office in Thailand, I'd like to express appreciation to Changhua Christian Hospital of Taiwan, Faculty of Medicine Ramathibodi Hospital, and Faculty of Medicine Siriraj Hospital, Mahidol University, for jointly organizing this online seminar. And I would also like to take this opportunity to acknowledge Changhua Christian Hospital for its hard working in promoting the medical exchange between Taiwan and Thailand over the years. Once again, thank you, and I would like to wish today's online seminar a fruitful and successful one.
Thank you, Mr. Shi. Next, I would like to invite Dr. Duangrurdee Wataganara from Faculty of Medicine Ramathibodi Hospital, Mahidol University, to deliver the remarks by Ramathibodi Hospital.
Your Excellency, Mr. Wei-Ming, the Acting Representative of TECO, Thailand, Professor Nina Gao from Changhua Christian Hospital, and the speaker, Professor Gu Shin Ma, Professor Chayada Tangshewinsirikul, and Professor Tuangsit Wataganara, and all participants. I am very pleased and feel very honored to be part of this special event, the first prenatal and pre-gestational diagnosis, hosted by Changhua Christian Hospital, Ramathibodi Hospital, and Siriraj Hospital from Mahidol University. As a pediatric clinical geneticist myself, I can confirm that genomic medicine is such an exciting field and has grown rapidly in the recent years. Genomic tools have been used markedly across our specialties, both in clinical service and research. Reproductive genetics and preventive genetics is not an exception. There are so much to learn from specialists and researchers from various countries. Because we are different, we have different clinical settings. We also see patients from different ethical, cultural contexts. And therefore, I believe that this seminar will lead us to expanding the knowledge, exchanging experience among the speaker and participants. And I wish for the best and fruitful meeting to all. Thank you.
Thank you for Dr. Duangrurdee's opening remarks. Next, we would like to invite Dr. Nina Gao from Changhua Christian Hospital to deliver the remarks by Changhua Christian Hospital, please.
Yeah, Thank you, Meng-Shin. Good afternoon, ladies and gentlemen. It's my great pleasure to join today's seminar. So I'm Nina, the director of Overseas Medical Mission Center of Changhua Christian Hospital, the one of the co-organizers of today's online seminar. First of all, I would like to thank today's moderator, Dr. Meng-Shin, my best friends, to assist. We invite speakers from Rama and from the Siriraj Hospital of Thailand to share their experience about the prenatal genetic diagnosis. Changhua Christian Hospital is a medical center in central Taiwan with 9 branches. So we have very strong IVF team and also the prenatal genetic diagnosis team to work together to detect the genetic diseases in the very early stage of pregnancy. So I know the Thailand, the faculty of Mahidol University, Ramathibodi Hospital and Siriraj Hospital, and are both of the top of the medical center with excellent research in Thailand. So I discussed with our moderator today, so maybe we can organize a seminar to share the result of the latest research for each other. So finally, we organized 2 sessions as our moderator mentioned earlier. One will be on May 16 and the other one will be on May 13 respectively. And we will invite different experts to share their knowledges and experiences. So finally, on behalf of the organizer, Changhua Christian Hospital, so I would like to thank Professor Duram, Department of the Pediatrics Rama Hospital, and acting or representative of Taipei Economic and Cultural Office to support our event. Also, I would like to thank all of our 3 speakers today from Changhua Christian Hospital, from Rama, from Siriraj Hospital. Thanks to take your time to join us today's seminar. Finally, I think today's seminar will be successful and you will get the innovative insight. Thank you so much.
Thank you, Nina. Even Nina could not come to Thailand for the past 2 years, but we actually worked together for donating some personal, a lot of personal protective equipment, masks,
yes,
and even the antigen test kit to different hospitals in Thailand, including Rama. So we have been working very well in international collaborations.
That's true.
Okay, so I think before we started the presentation today, based on Thai culture, we need to take a group photo together. Is it your tradition as well? Like everyone has to open up the camera and then take photos together?
Okay. I don't know how. Oh.
So it's our tradition in Thailand that everyone has to take photos before the seminar starts. So please, everyone, we'll wait a couple of minutes for people to make themselves look nice.
Yeah.
So
you will say 1, 2, 3.
Is it like, let's wait for a couple of minutes because some people, they might not ready to take good photos. So yeah. So I saw Dr. Chayada, I saw our guest, and I saw Tuangsit. Hi. Okay, so I think we have the main speakers and host in this photo. So let's take. Nina, are you have your assistant to take screenshot, or I will do it?
Yeah.
Okay, you have your assistant.
We'll do it.
Okay, let's
and then
say
we'll share to you.
Cheers!
Yay! Okay.
Okay, thank you, everyone.
Thank
so
you.
let's start. I would like to invite the first speaker today, Guo Ma. Actually, he was my classmate in PhD study. So we have been knowing each other for, I won't say how many years, maybe only 5 years since my PhD. So he has been working in prenatal and preimplantation genetic test for a long time. So it's our great honor to invite him to deliver the talk today entitled Prenatal Relevance of Maternal Copy Number Variation at Chromosome X in Male Fetuses. Okay, let's welcome Guo Ma, Dr. Guo Ma, please.
Good afternoon, everyone. Thank you for coming. And thanks for the introduction of Dr. Xiao, as well as the invitation of the team and the CEO of the Overseas Medical Mission Center of CCH, Dr. Gao. I'm Guoqing Ma, the Deputy Director of Department of Genomic Medicine, Changhua Christian Hospital, Taiwan. I'm pleasure to be here to share my experience in prenatal diagnosis and prenatal diagnosis of genetic disorder. Genetic disorder is a large and complex group of disease caused by genetic defect. Titles of genetic disorder are also rare disease. Therefore, the diagnosis of genetic disorder are not easy. Many families have gone through years of diagnostic odyssey from one specialist to another, trying to find the cause of their familial disease. Currently, more than 7,000 monogenic disorder and more than 1,000 chromosome disorder has been reported. The underlying cause of genetic disorder are also heterogeneous. Genetic defect can occur in the DNA or chromosome levels and includes mutation types of deletion, duplication, translocation, inversion, point mutation, and so on. To cope with various genetic defects, while a variety of genetic tools are required and has been performed. For example, cytogenetic analysis is able to find chromosome change, but cannot detect point mutation, but may rely on the use of DNA sequencing. Small piece of chromosome deletion and duplication are called as copy number variation, CNVS. CNVS that cause genomic imbalance and gene dosage change. Many unexplained physical findings such as developmental delay, autism, multiple congenital anomaly has been associated with CNVS. Clinically, CNV are not uncommon. Its incidence was estimated to be 0.7 to 1 per 1,000 births. CNVS are small in size, generally less than 2 to 5 megabase, that cannot be identified by the microscopy. Therefore, CNV are also called as microdeletion and microduplications. A number of diseases are known to be caused by CNV, such as DiGeorge syndrome, Williams syndrome, and so on. To diagnose these microdeletion and microduplication disorders, molecular cytogenetic analysis such as FISH or molecular analysis such as qPCR, MLPA are commonly used to identify the targeted CNV. These analyses are for targeted diagnosis that must be arranged based on the clinical symptom in which a disease has been suspected. However, not all fetal anomaly can be noted or linked to disease during the prenatal period. Therefore, arranging a targeted test for fetal diagnosis is not always feasible. Array-CGH is a FISH-based method that allows the genome-wide scanning of CNVS by comparing the fluorescence signal intensity of the sample DNA and the reference DNA. Information related to the clinical condition of the fetuses is not necessary. Pathogenic CNV detected by array-CGH can be related to the corresponding disorders. For example, deletion in the chromosome 22q11.2q region indicate a diagnosis of DiGeorge syndrome, also called 22q11.2 deletion syndrome. If gene related to monogenic disorder, that will include in the CNV, such as DMD gene of the Duchenne or Baker muscular dystrophy. The monogenic disorder can also be identified by array-CGH. Sometimes variants of unknown or uncertain significance may also be detected by array CGH. These CMV are called as VOUS. VOUS may be found in patient group as well as in healthy human population. According to the guideline provided by ACMG and the AMP, variants can be classified into 5 categories. These are pathogenic, like pathogenic, VOUS, likely benign, and benign. Actually, a significant number of CMV detected prenatally is classified into the VOUS, most due to the heterogeneous nature of most disease. Application of array CGH to fetus instead of postnatal phenotypically abnormal individual face a much more difficult circumstance. First, not all CMV detected prenatally are associated with unfavorable outcome. Typically, the interpretation of possible clinical consequence of CMV relies on cases with similar CMV as reported in the literature and the public database. Second, the majority of the reported genotype and the phenotype association of CMV are based on postnatal study. Namely, the reference database comes from affected subject, providing a biased inference. Furthermore, lots of abnormal phenotypes such as hypotonia, developmental delay, intelligent disability cannot be noted until infancy. This discrepancy renders the prenatal diagnosis of CMV challenging. To prospect the clinical consequence of CMV in prenatal case, multiple lines of information must be taken into consideration, such as the result of image examination, reported case with similar CMV, result of parental follow-up analysis, as well as the size and the gene included in the CMV. Moreover, when dealing with CMV on chromosome X, or so-called SCMVS, the gender information must be also considered. A higher risk is expected in male than female, since male only have one chromosome and one chromosome X, and the genomic imbalance of the chromosome X can cause abnormal consequence. Here, I report our experience in the investigation of the prenatal relevance of maternal SCMV in male fetus in 4 unrelated families. The family 1 and the family 1 and the family 2 have a male fetus with similar SP22.31 duplication, and the family 4 has a male fetus with SQ28 duplication. The family 4 had a pregnant history of fetal SQ28 duplication and have uptake for TOP for the previous pregnancy. The family 3 has adopted TOP for fetal SQ22.31 duplication in other hospital. The family is IVF with PGD for the SCMV. In short, the families 1, 2, and 3 have a male fetus with SP22.31 duplication. The family 4 has a male fetus with a recurrent SQ28 duplication. The SP22.31 duplication detected in families 1, 2, and 3 are similar in location, but different in size. The black bar shown here indicate the SP22.31 duplication detected in families 1, 2, and 3. The duplication overlapping with the reported pathogenic SP22.31 duplication, the gray bar, that were associated with mental retardation and multiple congenital anomaly. However, a complete literature review showed that the clinical significance of the SP22.31 duplication is still under debate because the duplication was also found in healthy human population. We thus consider that the SP22.31 duplication are of VOUS. The black bar indicate the duplication detected in families 4 that almost overlapped with the segment of a reported pathogenic SQ2 duplication, the gray bars. All reported patients with pathogenic SQ2 duplications were characterized by mental retardation. As a result, the SQ2 duplication detected in families 4 was initially recognized as a pathogenic SCMV. Prenatal follow-up was performed for the 4 family, and the result demonstrated that all of the 4 SCMVs are maternal origin. In order to get more information for genetic counseling and extended analysis, including more relative of the maternal lineage, was performed. Unexpectedly, in all of the 4 families, the SCMV can be found in at least 1 male members who are healthy without abnormal feature. You can see the arrow rays indicated the healthy male. The relevance of the 4 SCMV detected in male fetus will thus be considered as likely benign in this 4 family. The presence of healthy male relatives reassure the pregnant women before they opted for TOP. All of the pregnant women decide to continue pregnancy. And finally, all of the 3 male babies were born. Before I present this case here, all of the babies delivered normally without ID feature for 3 to 4 years old. The remaining 1 woman seeking IVF with PGT detect to choose natural conception. For clinical reference, we provide a flowchart for the prenatal implantation of SCMV, CMV characterization, data research, clinical data analysis, literature review, and determination of the inheritance are critical for CMV interpretation. For SCMV, the fetal gender must be taken into consideration. For male fetus with maternal SCMV, and expanded analysis, including more male relatives in the maternal lineage, is essential. Maternal SCMV that are also found in healthy male relatives may be tentatively considered as likely benign if no other fetal anomaly were found. However, it should be known that risk such variable expressivity and reduced or incomplete penetrance should be emphasized in the prenatal counseling. In conclusion, some reported CMV previously recognized as VOUS or even pathogenic can be found in healthy individuals, indicating a phenotypical heterogeneity of CMVs. It should be kept in mind that abnormality is just a form or phenotype for prenatal case with some CMVs. Besides, an extended study in addition to parental follow-up analysis may provide additional information for prenatal counseling as well as that I show in this study. certainly more rigorous clinical approach to understand the molecular mechanism related to the CMV are still necessary. For example, to understand the variable expressivity, decreased penetrance, skew S inactivation of SCMV. Okay, leads the staff of our department. I would like to thank them for their help in this study. Also, thank you for listening.
Thank you, Dr. Guotima. I think I got the message from the host that we will have a panel discussions in the end after all three speakers presented. So if you have questions and you are afraid that you will miss it or you forget, please type into the chat box and we'll check the questions in the end. So we'll continue to the second speaker, Dr. Chayada Tangshewinsirikul. Hopefully I pronounce your name okay. She will present, she is from Faculty of Medicine, Ramathibodi Hospital, Mahidol University, and she will present the title of Clinical Utility of Molecular Autopsy by Exome Sequencing in Fetuses with Structural Anomalies. Please, Dr. Chayada.
And good afternoon, Dr. Nina, Dr. Meng-Shin, Dr. Guojinma, and Dr. Wataganara, and all participants. And thank you, Changhua Christian Hospital of Taiwan for inviting me today. I'm very pleased to share my experience about prenatal diagnosis from maternal fetal medicine, Ramathibodi Hospital. Today, I will talk about clinical utility of molecular autopsy by exome sequencing in fetuses with structural anomalies. Fetal anomalies are identified roughly 5% of pregnancies and are responsible for 20% of perinatal deaths. Anomalies can range from a single minor defect to severe multi-system anomalies. And nowadays, we have conventional prenatal testing, includes QF-PCR, karyotyping, and chromosome microarray analysis. QF-PCR finds trisomy in around 30% of normal fetuses, and karyotyping identifies unbalanced chromosomal rearrangement in a further 5%. CMA finds additional pathogenic copy number variants in 3 to 6% of abnormal fetus with normal karyotypes. And using this test in combination, an underlying genetic etiology can be identified in up to 40% of dysmorphic fetuses. And there's still some genetic etiologies that cannot be detected from standard conventional prenatal testing. And as you see from this pie chart, that 20% of fetal anomalies caused by single gene defect or Mendelian inheritance. Genome-wide sequencing, including targeted analysis using clinical panels, exome sequencing and genome sequencing provides much greater resolution down to the single base pair level. In exome sequencing examines the coding regions or exons, which make up 1 to 2% of the genome, but contain more than 85% of all disease-causing mutations. Exome sequencing has been used successfully in adults and children to diagnose single gene defects and to identify causes of intellectual disability. In postnatal setting, exome sequencing has a diagnostic yield of 25 to 30%. Since 2014, several reports regarding prenatal exome sequencing for diagnosis of abnormal fetus have been published. In prenatal exome sequencing, diagnostic rates across 16 studies range from 6 to 80%. And the study with highest diagnostic yield of 80% had a very strict entry criteria that included parental consanguinity and fetal features highly suggestive of a syndrome for which multiple causative genes are known. However, there are important limitations when using prenatal exome sequencing. First, fetal phenotypic detail is necessary to identify the most appropriate candidate genes, but subtle dysmorphic features of many single gene defects cannot be identified using only fetal ultrasound. And some phenotypes are impossible to define from prenatal imaging, such as intellectual disability. And second, this test is hampered by long turnaround times because of the need to sequence and analyze the entire exome. Therefore, long turnaround times limits the use of exome sequencing for prenatal diagnosis, especially for reproductive decision making. And third, a high number of variants of uncertain significance can be found. It may create enormous anxiety and be challenging for patients and obstetricians and other healthcare providers. And finally, the current high cost of exome sequencing and limited insurance coverage for this genetic technology may restrict its use. Because of the limitations and the current absence of validation studies proving the clinical utility of this technology, the ACOG, SMFM, and ACMG currently do not recommend exome sequencing for routine use in prenatal diagnosis. Prenatal exome sequencing may be considered a diagnostic tool in selected circumstances, including in fetuses with multiple anomalies or in cases of recurring fetal phenotypes, and a diagnosis cannot be made using standard genetic testing. Moreover, exome sequencing should be ordered after extensive counseling and consultation with a clinical geneticist who is familiar with these new technologies and their limitations. Another use of exome sequencing for the genetic diagnosis of fetal structural anomalies is molecular autopsy. Prenatal ultrasound findings and postnatal and postmortem phenotyping together with exome sequencing improve the identification of genetic disorder in fetuses with structural anomalies. The use of exome sequencing as a molecular autopsy has been reported to give a diagnostic yield of 12 to 57% in small cohort studies. Clinical utility of molecular autopsy by exome sequencing has been proposed. First, it can expand knowledge of the prenatal phenotype and improve understanding of human fetal development. And second, the genetic findings assist assessment of recurrent risk in future pregnancies. In cases with de novo findings, it is possible to reassure the parents of a low recurrence risk. And those with recurrent risk then have the option of pre-implantation genetic testing for monogenic disorders and prenatal diagnosis in subsequent pregnancy. And third, in situations in which time constraints do not allow the performance of prenatal exome sequencing, the option of exome sequencing after termination of pregnancy or neonatal death is still available for couples who wish to investigate the etiology of anomalies identified during the pregnancy. So I will share some findings from our retrospective study at Ramathibodi Hospital. The objective of the study we made was to report the initial experience and diagnostic yield of molecular autopsy by exome sequencing in fetuses with structural anomalies in a clinical setting. And I will also demonstrate the clinical utility of these exome sequencing results in our clinical practice. At the fetal anomaly clinic in Ramathibodi Hospital, pregnant women who had severe fetal structural anomalies resulting in termination of pregnancy before 24 weeks of gestation or neonatal or infant death were counseled regarding the possible causes of death and offer an autopsy. In cases with suspected causes of anomalies from single gene disorder, exome sequencing was offered by the MFM specialist and pediatric geneticist, and parental decisions were made autonomously after comprehensive genetic counseling. The sample was collected from fetal tissue and fetal cord blood after termination of pregnancy or neonatal peripheral blood before neonatal death, and DNA was extracted. DNA samples were transferred to outsourced lab for exome sequencing and initial bioinformatic analysis. MFM specialist, pediatric geneticists will review clinical phenotypes together and transform to the corresponding standardized HPO terms. And then candidate genes were listed. In-house genetic lab analysis was performed by pediatric geneticists and clinical scientists at our institute. Candidate variants were reviewed and classified using ACMG guidelines. Pathogenic or likely pathogenic variants were confirmed by Sanger sequencing. And parental Sanger sequencing was also performed to determine patterns of inheritance. A retrospective chart review was conducted between 2017 and 2020 at Ramathibodi Hospital. During the study period, 22 cases of fetal structural anomalies with suspected single gene defect following termination of pregnancy or neonatal or infant death were recruited. This comprised 14 cases of termination of pregnancy and 8 cases of neonatal or infant death. Of these, 9 cases had normal karyotype, and CMA results were available for 3 cases, and these were normal. An autopsy was performed in 14 of the cases. Most of these had a good correlation with the prenatal ultrasound findings. Pathogenic or likely pathogenic variants were identified in 15 of the 22 cases and giving a diagnostic yield of 68%. There were 7 fetuses after termination of pregnancy who had positive results from exome sequencing. Pathogenic or likely pathogenic variants were identified for the skeletal system in 6 cases and for the kidney urinary bladder system in 1 case, and 5 cases affected with osteogenesis imperfecta, Apert syndrome or Hartsfield syndrome were found to have a de novo autosomal dominant alteration, and 2 cases of polycystic kidney disease and diastrophic dystrophy were inherited and in an autosomal recessive fashion, with both parents confirmed to be carriers of the inherited alteration. And osteogenesis imperfecta was the most common diagnosis in our study. There were 8 cases of neonatal or infant death who had positive results from exome sequencing. Pathogenic or likely pathogenic variants were identified for the cardiovascular system in 6 of the cases, central nervous system in 1 case, and skeletal system in 1 case. And these variants were in genes known to cause neonatal or infant death. And of these, 7 cases with osteogenesis imperfecta and Marfan, Noonan, and cardiofacial cutaneous syndrome or CFC syndrome were found to have a de novo autosomal dominant alteration. And 1 case of Joubert syndrome had a compound heterozygous variants with both parents confirmed to be carriers of the inherited alteration. And Noonan syndrome was the most common diagnosis in our study. Here are some cases details from our study. The first case is case number 25, a 38-year-old G1 pregnant woman, non-consanguinity. At 12 weeks, NIPT show a low risk of common autosomal trisomy, and at 23 weeks, ultrasound indicated polycystic kidney disease. The pregnant woman was referred to fetal anomaly clinic at Ramathibodi Hospital. At our clinic, GA 25 weeks, ultrasonography showed bilateral symmetrical enlarged kidneys with increased echogenicity and anhydramnios. There was no encapsulation or polydactyly, so the autosomal recessive polycystic kidney disease or ARPKD was suspected. Our hospital, 24 weeks of gestation is the cutoff for viability. So we offer termination of pregnancy if anomalies are diagnosed before 24 weeks of gestation. But in this case, the anomaly was diagnosed at 25 weeks. So a multidisciplinary team meeting was held to discuss the prognosis of the fetus. And after comprehensive counseling regarding the poor prognosis of the fetus because of pulmonary hypoplasia and renal failure, the pregnant woman decided to discontinue the pregnancy at 26 weeks without neonatal resuscitation. And cord blood was collected after termination of pregnancy. The fetus was sent for an autopsy, and it was performed by the hospital pathologist, and this revealed ARPKD with Potter sequence, which correlated with the prenatal ultrasound findings. Exome sequencing with targeted gene analysis of ARPKD was performed, and compound heterozygous pathogenic variants of the PKHD1 gene were found, and Sanger sequencing was carried out to confirm the diagnosis. Parental Sanger sequencing was also performed and showed heterozygous pathogenic variants of PKHD1 in both the father and the mother. So autosomal recessive polycystic kidney disease was confirmed. So the recurrent risk would be 25% in every pregnancy. And we know that ARPKD can be diagnosed by ultrasound in the late second or third trimester, which is late for parental decision to terminate the pregnancy. So PND by CVS or in the first trimester or amniocentesis in the second trimester for diagnosis of a familial mutation is helpful. And pre-implantation genetic testing for monogenic disorder or PGTM is also an option to avoid repeat affected fetus in subsequent pregnancy. And in this case, the parents opt for IVF with PGTM. Another case that I will show you is the case number 30. This case is a 39-year-old pregnant woman, G1. At 12 weeks, the first trimester scan show a thickening of nuchal translucency measuring 1 centimeter. So fetal anomaly, fetal aneuploidy was suspected. And at 17 weeks, amniocentesis was done for karyotyping. The karyotyping show 46XY, which is normal. Scan at 20 weeks shows cystic hygroma and very small VSD measuring only 1 millimeter. So amniocentesis was repeated for chromosome microarray analysis and CMA was normal. So at that time, the differential diagnosis was Noonan syndrome, and structure anomalies detected in utero at that time were not lethal. So genetic counseling was carried out and the pregnant woman decided to continue the pregnancy. C-section with tubal ligation were done per parental request. The parents did not want to have more baby in the future because they worried about pregnancy with advanced maternal age and they're depressed and they did not want to take risk of having anomalous baby in the future. Postnatal examination showed a newborn had nuchal edema with facial dysmorphism, and postnatal echo revealed moderate VSD, moderate size VSD, and bicuspid aortic valve, and heart failure from hypertrophic cardiomyopathy. And Noonan syndrome was suspected by the pediatric geneticist. As we know that Noonan syndrome involves Noonan-like syndrome involves Noonan syndrome, Costello syndrome, and cardiofaciocutaneous syndrome or CFC, which cannot be differentiated just from the clinical phenotype. Exome sequencing is necessary to clarify the genotype-phenotype correlations and thus enable a more accurate prognosis. this case, exome sequencing was done from DNA extracted from peripheral blood, and unfortunately, baby died at 10 months. Exome sequencing shows heterozygous pathogenic variant in the BRAF gene, and Sanger sequencing was performed for confirmation, and the diagnosis was CFC, or cardiofaciocutaneous syndrome. And parental Sanger sequencing was done and showed a de novo autosomal dominant alteration. So we could explain the cause of death in this case from prenatal and postnatal phenotypes together with exome sequencing without an autopsy. And because of their grief, and since a tubal ligation had been done, the parents decided not to have children in the future, even though the recurrent risk was less than 1%. And surprisingly, this couple returned to the hospital 2 years later. She was pregnant by IVF with PGT4 aneuploidy, and genetic counseling was given, informing the couple that the recurrent risk of CFC was less than 1%. But they were still worried and wanted amniocentesis for familial mutation for definite diagnosis. And amniocentesis was done, and the result was normal karyotype and no familial mutation. The fetus was normal and was birthed at term with a good Apgar score. So our findings suggest that molecular autopsy by exome sequencing is likely to be a feasible and valuable diagnostic testing option for pregnancy with fetal anomalies detected by prenatal ultrasound. The data also support the clinical utility of molecular autopsy with exome sequencing together with prenatal, postnatal, and full autopsy in order to explain the underlying genetic cause of structural anomalies, define the recurrent risk, and assist in the management of subsequent pregnancies. So I would like to thank Rare Disease Fund Department of Pediatrics Ramathibodi Foundation for the funding support, and my colleagues from Department of OBGYN, Department of Pediatrics, and Department of Pathologies, especially my lovely clinical geneticists and all dedicated MFM fellows and OBGYN residents. Thank you for your attention.
Thank you for Dr. Chayada's inspiring talks. We learned a lot, and we saw the very successful cases that they have healthy babies. So next, I would like to invite Dr. Tuangsit Wataganara from Faculty of Medicine, Siriraj Hospital, Mahidol University, to give us a talk, Fetal and Extra-fetal Sonogenic Assessment. Please, Dr. Tuangsit.
Hello, everyone. My name is Tuangsit Wataganara. I am a maternal fetal medicine specialist, and I want to thank the organizing committee for offering me an opportunity to share our experiences in using an ultrasound for a detection of fetal genetic syndromes. So first of all, the 2D ultrasound has been the staple of the prenatal detection, the prenatal screening of all the aneuploidies. But nowadays, the 3D ultrasound has become more and more adopted in our practices. Actually, there are a couple of systems of the fetus that 3D actually can pick up the anomalies better than the 2D ultrasound. For instance, the oral facial clefting with the 3D ultrasound is not only the fact that the 3D images can be used for a better counseling with the families. There are several functions of the 3D that can be a nice addition to detection of the cleft lip and cleft palate. For instance, this is a surface render, and you can appreciate the bilateral cleft lip of a fetus over here. And actually we use a little the silhouette mode. You can even see a little deeper. You can see the eyes, you can see the lens, you can see the maxilla and the maxillary process. You can see the mandible as well, and you can even see the cerebral structure. So that is quite a plus to the examination. If you use a silhouette and you adjust it to your preference and to accordingly with the organs that you want to visualize. For instance, it's the same face, a little different enhancement. Aside from the fact that you can make it like crystal clear and you can see deeper on the inside, so that you can relate the structures on the inside better with the surface landmarks. This is the thick slab 3D, and you can see that there is a cleft palate, on the anterior portion of the palate, of the hard palate. So you can see that the cleft lip is over here, and you can see the oral cavity. This is the nasal cavity, and you can see the continuation of the oral to the nasal cavity by using the thick slab 3D mode. So apparently this can enhance the detection of the 3D, of the cleft palate, which sometimes can be quite difficult on the 2D examination. The eyeball actually not only is a good landmark, and certain syndromes, may have abnormalities in either the size of the eyes, the numbers of the eyes, and the axis of the ocular axis. So this, you can see the posterior chambers and the lens, the posterior chambers and the lens, and I magnified it, and you can see that by using this axis, joining between the lens and the tip of the posterior chambers, you might be able to create a line that can be used as a reference plane for the low-set ear. For instance, this is a fetus at 10 weeks of gestation. You can see the orbit over here, and you can see that the ear is a bit too low. Of course, we do not diagnose the low-set ear, which we know that can be associated with a lot of fetal syndromes. We do not give a diagnosis of low-set ear at 10 weeks of gestation, but in combination with the thick nuchal translucency and this high suspicion of the low-set ear, well, it doesn't hurt to follow up on these infants. Don't you agree? And actually, the face is a very good example of how we utilize the 3D ultrasound to our practice. And if we just focus on the most common autosomal aneuploidies, the trisomy 21, actually you can appreciate the Down syndrome faces, which is the upslant of the palpebral fissure. The trisomy 18, actually the babies will show an early onset of fetal growth restriction. And for the trisomy 13, that is quite easy because you can see that the baby has only one eye, and it has a very, very seriously malformed facial defect, and especially the midline clefting. So for the bones, again, you can use the silhouette in combination with the thick slab to show the cranial valve, and you can see its relation of the ocular axis to the cranial valve, and you can see the mandible, you can see the frontal bone, you can see the parietal bone. Actually, if you flip to the back, you can even see the occipital bone on a separate, because they are not fused yet at this stage. The facial expression actually can be, has been suggested by some investigators as a way to see the neurological development of the baby. It could be used for a prediction of cerebral palsy in high-risk mother. Now, the second area of the fetal scanning that 3D can benefit over the 2D is the myelomeningocele. Myelomeningocele is a defect of the spinal canal, And if the defect is only at one particular level and not like, spanning through maybe 4 or 5 levels of the vertebral column, then it might not be so easy to pick up on the routine ultrasound. Some people advocate the use of the 3D ultrasound on the spine in order to detect the displaying of the lamina of the vertebral bones. And actually, this is an example of scoliosis, which at times can be seen, with the myelomeningocele. So you can use, again, you can use all kinds of enhancement to get a better view of the spinal. For instance, with the inversion mode, you can see overlaying of the lamina, and you can see that one of actually parts of one vertebral body is missing. This is an example of the hemivertebra, and this is a common cause of scoliosis in the newborn. And actually, it can be seen, demonstrated very clearly using the inversion mode of the and fixed slab in combination. The third area that 3D performs better than 2D is skeletal dysplasia. And apparently, if you can do the whole body scan or you can do the whole limb scan, you can appreciate how short and how bowing appearance of those long bones are. And the normal long bones actually can be demonstrated by can be enhanced by using the 3D ultrasound. And the 3D ultrasound can also demonstrate how contractures and how deformity, that the arms and legs may not be functioning properly at the time of birth. Again, you can appreciate either the upper arm or the lower extremities. And many of these actually can be appreciated as early as first trimesters of pregnancy. So timing for screening of fetal genetic syndromes, apparently, if you have a very thick nuchal translucency or cystic hygroma, especially in association with cardiac finding, it can be associated with trisomy 21 Turner syndrome or Noonan spectrum disorders. Apparently, this baby will deserve to have prenatal genetic diagnostic. And 90% of limb abnormalities actually can be picked up by an ultrasound in the first trimester of pregnancy. The second trimester anomaly scan after 18 weeks, the protocol-based scanning has been implemented in most places. The third trimester or scan, although it can be used to check up, follow up on the evolution of the lesion that we previously detected, it has not been endorsed to be the routine practice. So you can notice a continuous shifting from the detection of soft marker to the that may not be associated with structural anomalies to the detection of major anomalies when the gestational ages are progressing. It is important when you do the protocol-based ultrasound, because each and every operators can have a variety level of the experiences. So nowadays, the AI that is embedded in many machines actually can mandate the images in the right examination plane before it is being saved. It can be enforcing the checklist. For instance, the cleft lip, for the lip, you have to see this image, and then the AI will pick up that if this is the right anatomical landmark, and once it pick up all this, it will pass the exam of the upper limb scope, and you can go on to the next items. So fetal syndrome, actually, most of the time, the anomalies that you see on the ultrasound are oftentimes sporadic, and it's not genetic in cause. So other causes of abnormal fetal anatomy would include the infection, the substance abuse, the tumor. So and for some of those, may have the chromosomal and subchromosomal. So many times it's not so easy to differentiate between these two, because apparently, very few, of the anomalies are so characteristic that, that that the ultrasound can be used as a standalone tool for the diagnosis. So you have to diagnose it, by using either the CVS, the amniocentesis, or photosynthesis. It is good to know that in most of the syndromics, actually you can see from abnormalities in the heart or the great vessel examination. So being able to examine the cardiac structures at a very good accuracy is certainly a plus to the examination. For the infection, actually, if the baby is having infection, the placenta is the first organ that will got hit by the viruses, and you can see the swelling, you can see the calcification after birth, which means that there's the damages after the placental phase. And once the viruses can get into the fetus, it can manifest a variety of presentations. So placenta is certainly something that you cannot be missed during the examination. Also, the cystic appearances of the placenta could be associated with either triploides in partial mole, which you can see as a small for gestational age fetus in presence with the vacuolized placenta. The vacuolized placenta can be another possibility is a placental mesenchymal dysplasia, but in this case, the baby can be having the organomegaly and is not compatible with life. The certain psychoactive substances can cause ischemia in utero, causing the abdominal wall defect like gastroenteritis. This tumor, can be picked up by using the 3D enhanced like a cellulite mode. So this is an example of the macroplasia that can be visualized much better with the cellulite ultrasound. So if you want to go for the whole genome or whole exome sequencing, it is important to be reminded that sometimes fetuses with abnormalities may not have the abnormal karyotype or abnormal CMA, but although the whole exome sequencing can additionally detect 25% of newborn babies with dysmorphisms, the data before for the prenatal use is still very limited, and still, many of the results are still under investigational. So these are the major obstacles for an effective determination of the fetal syndrome. Okay, and this include because most of the time the third trimester scan is not always a routine, and a broad variety of the examiners, and also the centralization of the advanced test. So this is an example of the cleft mandibles. That usually the mandible will fuse at around 16 weeks of gestation. So if you can still see the clefting, especially when the baby is having a very small shin, that can be significant for the abnormalities. Functional imaging, like in this case, this is the image of the pulmonary vasculatures, can also be used to predict the outcomes, aside from the major defect. AI, has become more and more important because we know that genetic syndromes occur, like new genetic syndromes emerge every day. So it's nearly impossible for us to know all kinds of genetic syndromes. So we need to use the AI, and that can have an access to the most recent publications, so that it can make a prediction accordingly with the findings that we have on the ultrasound. So in conclusion, not all genetic syndromes can be identified prenatally, and it is important to set the expectation of the parents right. The first trimester scan can be an effective screening tool for selected genetic syndromes of all. Second trimester ultrasound is the most informative, as long as it is structured and systemic. The third trimester ultrasound is not a routine in most places, And the 3D and 4D may be useful in selected areas. The prenatal ultrasound to pick up these diseases can be useful for prenatal testing, for decision to go for determination, intervention, and for the prognostication, delivery planning, as well as neonatal management. And the AI seems to have a very bright future in the fetal ultrasound. And I just want to thank everyone for your kind attention.
Thank you for Dr. Tuangsit. I think it's a time for open for panel discussion, floor discussion, and I understand that some of you might not want to speak it out loud. So we are welcome. You all are welcome to type your questions in the chat box. But for some reason, I cannot see the chat box, so Dr. Nina will help me. I'm amazed for the 3D imagings because when I had my two kids, we didn't have this kind of very advanced ultrasound technologies. So any question from the audience?
Can I ask the two doctors from Thailand? So like the prenatal screening in Thailand, that is the cost is paid by the patient self or the hospital or the government insurance system can cover the loss of that prenatal screening, like a genetic testing. I'm not very sure.
Dr. Chayada, you wanted to respond to the question?
Yes, as I know, the national policy, they pay for maternal serum screening, only quadruple test, and prenatal diagnosis as indicated, and they also pay for safe abortion as well. Yes.
And they pay for thalassemia, for everything
yes, exactly.
about thalassemia. So
I think in Taiwan we pay for thalassemia as well.
Right. So our pain points are that they pay for one single ultrasound. So you have to pick wisely if you want to go for the very good first trimester screening, or if you want to go for the the more informative second trimester screening ultrasound. And the quad test, well, we know that it doesn't perform very well compared to the other kind of screening tests. But that's how the government works.
Mm-hmm. So for the hospital, do you have any responsibility, like do the public education for the ladies before they go into marriage, before they go into marriage? So we will encourage them to do like the screening or the testing before they are getting the pregnancy. Any of like the health promotion program in the hospital for the public.
Chayada, you can go first.
I think we try to promote, but unfortunately, I don't know, because of some limitation of the economic financial problems and education problems in Thailand. So most of pregnant women in Thailand, most of women in Thailand do not have a chance to do a preconceptional counseling and preconceptional screening. And most of them come to the ANC quite late at second trimester. That's why I think a national policy pay for only quad test, because they think that the combined test at the first trimester might not work.
My view is that first of all, as you can see from the first two speakers, that timing is everything. So even if you detect something like wrong, from either the CMA or the exome sequencing, so you need more time, to investigate deeper, either by molecular works or by follow-up ultrasound. So for me personally, anyway, if we see something at 20-week scan, for me it's a bit too late. Except if the thing that you are seeing is a thing that's so common, like the common autosomal aneuploidy, so that would be very easy. But as I showed you from my slide before last, that genetic syndromes occur, the new genetic syndromes are being discovered every day, right? So we are running on a very time crunch to offer the family if the finding that we are seeing here, first of all, how big is a clinical ramification, and if it will recur in subsequent pregnancy. So these are two major questions that we need to answer within such a time crunch. So now you understand where I'm coming from. So why I'm so like promoting the first semester assessment. That's my view anyway.
Yeah. We have a question from the chat box that we're going to address to Dr. Ma. So how about non-invasive prenatal testing screening in Taiwan? Yeah, Ma Bo.
Yes.
Yeah. Do you see the question in the chat box? How about the non-invasive prenatal testing screening in Taiwan?
I think many women choose the NIPT for prenatal diagnosis, but personally, I don't prefer this method because he have his drawback, such as it maybe make the false positive and false negative. This is the biological problem, not the technical problem. This is due to the cell-free DNA is measured from the placenta, not from the fetuses. So maybe sometimes the NIPT result may be negative, but the fetus may be trisomy 21 positive, and the result may be fine after the baby was born. So I prefer the invasive method remain the golden standard for prenatal diagnosis. Okay.
May I add something here, just quickly?
Sure. Yeah.
So on the next conference on the 30th, right? So
yeah,
I will be talking about the NIPT because as Siriraj Hospital, we do have our own in-house NIPT. So although we are not regulating how the practitioners all over the country would offer their NIPTs, because apparently nowadays the labs, the private labs, are using the direct-to-consumer policy to offer that NIPTs to the pregnant women. So it will be irrelevant for us trying to impose any rules onto the nation. But we do have some, experiences and some, well, let's say painful experiences more likely in our utilization of NIPT in our practice. So, and I do not disagree with doing the traditional approach of the invasive test, but we have to admit the fact that now NIPTs are being used more liberally, and we need to live with that. That's my experience.
I have one question for Dr. Ma. So do you have any case that it's female and it has the XCMV, the CMV copy number variation on the X chromosome, but it's a female patient, female baby? Because from
yes.
all your cases, it all are males, right?
Yes, we have females patient with X chromosome recessive disorder, not CMV, such as the hemophilia A. But I think female with SCMV will be affected if female carriers suffer from skewed X chromosome inactivation, by which the wild type gene doesn't express as is usual. Besides, I consider female compound heterozygous for one SCMV and unidentified genetic defects are also affected. So application of another diagnostic tool, such as the NGS, may be helpful for the prenatal diagnosis. Yes, it is my comment. Thank you.
Another question is that since I think the cases that you collected are very particular. All the affected members are male fetus, and then actually the carrier, the original carrier, was their grandfather. So I understand that prenatal diagnosis doesn't involve like you have to figure out what's the mechanisms, but is there any plan that you try to figure out why this will happen coincidentally in many different families? Like it's very, very, very particular pattern. The XCMV is actually from the mother, and then it's the mother's father. So it's grandfather from the mother's side. But and they are all like benign. So is there any chance that your team or anyone else will try to figure out what is the cause?
Yes, I know. Different family member with the same genetic change may be affected differently. This is called variable expressivity. And some carriers may even present no feature of the disease. And this is called reduced or incomplete penetrance. In this report, I have emphasized that the CMV found in the 4 families were tentative, considered as likely benign in the prenatal setting. This result just provides additional information for the genetic counseling. The decision, actually, the decision is a trade-off between having a baby and taking the risk of abnormal phenotype for the couples. Okay.
Okay, thank you. Is there any other question from the chat box? No.
No. Yeah. No.
Actually, when I was pregnant, I did NIPT 10 years ago. But at that time, I think we only can do 3 chromosomes at that time. We are only confident with 3 chromosomes. And then when I was like 10 weeks pregnant, we have to make reservation for high resolution ultrasound at certain weeks, so it won't be too late if there's anything wrong. So the timing is also very important, as what all the speaker mentioned. So that's from my own experience 10 years ago. So I think it's much more improved for the technology these days. We have all the improvement. Okay, so how about Dr. Nina? Do you want to make the conclusion remark?
Okay. Oh, Dr. Ma, he has a question. Please.
Okay, I have a question for Dr. Chayada. How about you thinking about the use of the whole-exome sequence in fetuses? Because the result may find a lot of VOUS. So I hope you can talk about your thinking. Thank you.
So do you mean exome sequencing in prenatal state, right?
Yes.
I think if we have that case, it would be help for the families to make a decision that they want to continue the pregnancy or terminate the pregnancy if the result come out was positive. But unfortunately that we don't have that case. I think the most important factors is that the long turnaround time and also the VUS of the result. I also did my retrospective research with my residents and about the termination of pregnancy rate at Ramathibodi Hospital and factors associated with the parental decision. And we found that over 50% of parents decided to do the termination of pregnancy when fetal structural anomalies was detected in utero. And the most powerful factors is severe fetal anomalies. So that even we don't have a prenatal whole exome sequencing and we don't have a definite diagnosis of the genetic disorder in the fetus, but the parents still decided to terminate a pregnancy anyway. But I think in the future, if we have this test, it should be great for us. Not a whole exome sequencing, but just genes panel. It should be great. Yes. Dr. Ajahn Tuangsit, do you have any comments about this?
Yes.
I just want to remind everyone in the audience that may not have such a level of knowledge that Dr. Chayada and Dr. Ma, that we have to be careful because, first of all, the legislation in every country to allow for the termination of pregnancy based on the prenatal findings are different. In some countries, you can just go into a clinic, without any indication, you can ask for elective termination. In some countries, like even in Thailand, if your babies are prenatally diagnosed with the 22q deletion, you will have a hard time getting the termination. Trust me, this is a reality because of the for Down syndrome, the delayed development is homogeneous. It will be deeply retarded. But for 22q, the degree of retardation could be varied significantly. And right now, there is no way for us to predict, how well the baby will develop mentally, after birth. And if we include the whole genome or whole exome sequencing into the equation, it will even complicate the landscape of how would we, first of all, we don't really know much about it yet. And second of all, we still need time to educate the legislature to be on the same page with us. So you know what I mean. So for now, for me, I think the whole exome is the way. Yes, we should gather more information on this. Certainly, it should still be treated as an investigational basis. Like at my center, we're doing a lot of fetal intervention, but we're doing it on investigational basis. Any procedures that still do not have unproven benefit, we need to be very frank and honest to the patients as well. Okay, so that would be the precaution that I'm taking at the moment. Thank you.
Can I ask a question from Dr. Ma?
Yes, please.
Do you always use chromosome microarray analysis in prenatal setting? And is it the first tier test for the prenatal diagnosis in your setting? Or what is the indication to use the chromosome microarray analysis?
Microarrays performed in Taiwan as a screen method, as like the cytogenetic analysis. So it's very common method performed prenatally. Okay.
I think the next seminar, Dr. Chen, we are talking about some of the microarray, is right?
Yeah, but I think Dr. Chayada's question is that, is there any criteria that you decided to prescribe array CGH based on ultrasound, based on certain diagnosis? You see the abnormalities from ultrasound or something like that, then you can, what is the SOP for prescription of array for patients? Maybe we'll leave the question for Dr. Chen next week. I will remember this question for him. He's the OB. He's OB-GYN. So
yes.
So I'll remember this and ask him next time.
He's the director of the department. We will leave the question for him.
Yes, some question I can answer because I work in the laboratory. So
for the more clinic, Dr. Chen can be answered because he is also a doctor. Yes. Clinic doctor. Yes.
Okay, sorry for that question because in Thailand I think array is quite expensive. So we try to use it when the fetus has an anomalies and normal karyotype. We offer array to the patients, but patients usually denied it because it's like have a high cost. Yes.
I think our the national health plan in Taiwan, do they cover it if the doctor think it's necessary to do the array? They cover it, right? The national health plan insurance in Taiwan, they cover the array?
No.
It's
there is a self-pay test.
Oh, maybe I should ask how much is it in Taiwan?
About
50,000, I think.
I think $700 to $800.
7to2万多块吗？
Yes,
25.
Okay.
I think in Taiwan,
Okay.
in Thailand it's about that. Maybe they increase a little bit.
About 20,000 Thai baht. 20,000 to 25,000 Thai baht.
I think it's around the same price, but you know the income is different between Taiwan and Thailand. Yeah. Dr. Meng-Shin was like, But I know in Thailand, because we are luckily in Bangkok, we have Ramathibodi Hospital and Siriraj Hospital and also Chulalongkorn Hospital. But in Thailand, the differences between rural area and the city is very, 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 very different. It's not like in Taiwan, you can reach all the centered and universities, hospital. Just
can they add something here?
Sure, please.
Well, to my knowledge, in this part of the world, it's very difficult to implement the CMA or the exome sequencing into clinical practice. One important thing is that because most of the genetic amniocentesis or CVS even is done for karyotype study, like 95% over, of the time. And ideally, it should have been the CMA and the exome sequencing should have been a reflex test to, well, if you see some abnormalities from the ultrasound, you do the invasive test, then the QF-PCR happens to be uninformative, then the samples should be automatically forwarded to the CMA and the sequencing respectively, right? That is ideally. So the patient would not have to get a repeated procedure to for the genetic testing, but that's not the things that's being practiced in this part of the world. Am I right? I'm not sure if that's also the case in Taiwan, because whenever the result of the amniocentesis comes back negative, oftentimes the lab will ask for more samples, which it means that we have to go in again, and it also means that the patient have to pay even more for that, which so that's why CMA is not like widely adopted in this part of the world. Well, I'm not sure if that's always the case in Ramathibodi and in Taiwan.
Any comment?
So actually my point, when in my presentation is that if you are good enough at the ultrasound, so now we have to go back to the ultrasound. If you're good enough at the ultrasound, you know that the conglomeration of the findings may not be consistent with common aneuploidies, then do not waste the time and money, to go for the full karyotype. Just a QF-PCR, you can ask the lab to do the kind of reflex test right away. So even though ideally reflex test should have been like universally applied, but well, in reality, if you suspect that this is not the case of common aneuploidies, you can inform the patients and inform the lab well in advance that, okay, this sample, you may want to take a bit more samples. Like for the CVS, you may want to do the transcervical CVS so that you will get a high quality and a bunch of samples that will be adequate for the trio, we call the trio test, the QF, the CMA, and also the whole-exome. So that would be the ideal practice. That's my personal suggestion anyway.
Yeah, total agree. Yes.
Yeah, I agree too, because when a woman is pregnant, when they hear maybe we will do more tests, that will totally cause the anxiety of them. And if you do more tests and you cannot explain all the abnormalities because we have never found them in any publications, then they will be like totally crushed by all those results. So it has to be very, very careful. Advise them to do more tests and also explain the results for them.
Yeah.
Okay, so I think it's a fruitful discussion today, and I would like to invite Dr. Nina to give us a conclusion remark.
Okay, thank you so much for our three speakers to join us today, and also thanks to all of our participants. I hope that from today's discussion we have more ideas, and in the future, if possible, I hope that Changhua Christian Hospital has the opportunity to can working with the Rama or the Siriraj Hospital, in the such of the kind of researches. So our next of the seminar will be on May 13th. So I also hope that all of our participants can join us in the next of our online seminar. So once again, thank you so much, and wish you have healthy and safe. Thank you.
Bye.
Bye.
See you next time.
See you next time. Bye-bye.
Bye.